Well, hello and welcome to the 27th Degree with Chris and Nancy, being broadcast from the Bioskills of the Northeast Studio in Fall River, Massachusetts. Today we'll be discussing the Hospital at Home program with Dr. Eric Alper. Before we begin our conversation, I'd like to thank our sponsors, Bay Coast Bank. Bay Coast Bank is just right for all your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. And Duncan Hearing Healthcare you can trust, with sites in Fall River, Dartmouth, Falmouth, and Centerville. For more information, visit their website, duncanhearing.com. As always, you can support the 27th Degree with Chris and Nancy by subscribing to us on YouTube or your favorite podcast platform, and by following us on Facebook and Instagram. And also, please remember to leave a review. And of course, 5-star reviews are greatly appreciated. So before we get going, Eric, of course, I didn't mention this, but Eric and I went to medical school together. So we are good friends and we've known each other greater than 30 years now at this point. But for the audience, tell us a little bit about yourself, Eric.
Thanks, Chris.
Actually, I should.
Nancy.
It's okay if I say Eric, because it's going to be weird saying Dr. Alper. I'm sorry, but even though
I'm good. Yes,
all right.
Yes, I am a doctor, but yes, I think you don't have to call me Dr. Alper. Most of the people at work call me Eric. So please, please call me Eric during the interview. But yes, I am a physician trained with Chris at UMass Medical School. Back in the day, we both did our residency training in internal medicine at UMass as well. And I've been working as a hospitalist for the past 25 plus years, as a small percentage of my time, and mostly in the last 5 to 10 years. So I've been spending most of my time doing healthcare IT work as well as quality improvement work. And the healthcare IT work has been largely involved with implementing electronic health record systems. Here at UMass Memorial, we implemented Epic about 8 years ago, and we're really proud of the work that we've done in that space. And I think Epic has improved a lot of things for us, but there are some things that we are still working on outside of Epic as well. We've had a number of challenges that we've needed to address with other kinds of digital solutions and platforms, and I think we'll talk about some of those today. And Hospital at Home, I think, is one great example of the way that we're using some digital tools to help us to take better care of patients, throughout our healthcare system.
Great. So I'm suspecting that this is a term that's alien to most people who are listening to this show. I mean, it's not something that I really knew a lot about before we had some discussion. So maybe we can just start with a very kind of high-level view of kind of what it is.
Yeah, so I think, this idea first arose probably back in the 1990s, where I think it was at Johns Hopkins. They decided to say, and I think it was a geriatrician who said, I've got all these patients, my elderly patients, I'm admitting to the hospital, but I think that we could have just as good, if not better, outcomes by taking care of sick patients in their homes with the right supports at home. And actually, there have been quite a few research studies that have evaluated this over the past 20, 30 years that have been really highly favorable, that show that you can deliver care for a patient who has acute medical illness safely, effectively, and depending on the circumstance, at a better cost. We are well. Let me just start by saying, back in 2020, when COVID hit, and we now had this challenge where we wanted to try to take care of patients as well as we could, but not to bring too many patients who were COVID positive into our hospital spaces, which would threaten our staff. And then, in theory, we might expose patients who didn't have COVID, who needed to be in the hospital.
Sure.
They would get COVID. So to keep patients who were eligible to receive care at home, to keep them in their home, that we would provide support for them at home. And it was at that point that the government decided to allow a waiver that said that you're able to take care of acutely ill patients in the home. I should say the waiver was that you don't need to have 24/7 hospital care or 24/7 nursing care. Um, so that enabled us to be able to get patients to receive hospital level care at home. And that's basically when we started our project back in 2021. We decided we wanted to create this program. We wanted to keep patients out of the hospital. We thought that we could take care of patients just as well, and we've been doing it ever since. And I can tell you a lot more about that. But does that answer your question, Chris?
Yeah, no, that's great.
So you were talking about patients with certain illnesses that are appropriate for this type of program. Can you kind of go into that a little bit more?
Definitely. So I think that there are some types of conditions that are probably more amenable to getting care in the home. And I'd say kind of our sweet spot is patients who have COVID, patients with pneumonia, patients who have heart failure and require intermittent intravenous medication to get them to get rid of some of that extra fluid that they have on board. Patients with emphysema, or what we call exacerbations of COPD, where they are needing to have intravenous steroids or medications that just requires that it takes time for them to get better on that medication. And I think that so I would say that those are the kinds of patients that we're typically looking to get home. And that's actually a large percentage of patients
Absolutely.
who are admitted to the hospitals these days. I think we also look for, a number of criteria to say, do we think this patient's going to require advanced imaging in the hospital? Are they going to require a procedure in the hospital, like an endoscopy? Are they going to require dialysis? These are the kinds of things that would say, yeah, you're not the right person to get care in the home, because we don't want to have to bring you back and forth for all of these services. But for the vast majority of these other patients, we can deliver care really very safely. And we've taken care of some very, very sick patients in their home as well with the tools that we have to monitor. And we've had extraordinarily positive results.
Eric, how are you getting these patients? Are they patients from the ER that the ER docs can like flag you and say, hey, I think this patient's great? Or are they in the doctor's offices?
So in order, under the CMS waiver, you need to have a few things in place in order to offer a hospital at home program. First of all, the patient does need to have an emergency department visit prior to having the patient come in. So in current state, we're not able to take patients directly from doctor's offices. They need to go to the ER first. We need to have in place a command center where we have our physicians, nurses, other caregivers. We have EMTs that are part of this as well, care coordinators, just like you might find in a hospital inpatient ward if the patient is admitted to a regular, what we'll call a brick and mortar hospital. We have a technology platform. In our case, we're using largely our electronic health record, Epic, to deliver a lot of the things that we would normally do for any other patient. We write orders, we write notes in Epic. We take care of the patient in many ways through Epic, but we also have some additional technology that we use for remote monitoring. We have a little gizmo that we put on a patient's arms that tracks their heart rate, their respiratory rate, their pulse oximetry. We can follow their blood pressure in the home, et cetera. Just like, again, you might see if the patient was in the hospital. All of that data winds up interfacing back into our electronic health record so we can see that data at any point in time. And then we have a series of what we call acute rapid response services, which include things that you wouldn't necessarily expect that we'd be able to bring into the home, but we can bring medical supplies into the home, durable medical equipment if needed. We can bring oxygen into the home, oxygen concentrators for patients who need it. We bring medications into the home. We can even bring mobile imaging into the home through some partnerships that we have. We can get chest x-rays, echocardiograms, ultrasounds, other things that you would think, geez, you really need to be in the hospital. But in fact, I think maybe Chris, in your work is taking care of patients in a skilled nursing facility, then you can frequently have someone come in and do an X-ray, so you don't have to send a patient back to the hospital. We're using similar kinds of services for that.
That makes sense. Now you say that, yeah.
Yeah, the physical therapy, occupational therapy, we get all of this into the home, and then we do twice daily nursing visits in the home. We do a physician visit once a day through telehealth. And I'm sorry, Nancy, I realize I didn't answer your question. Patients need to have that emergency department visit. And then once we decide, you're a good patient for this, then they will send a referral over to our hospital at home team. They'll take a look at all the information. We have a number of communities in our area that we are able to send our team out to, and because our nurses have to drive, we can't send our nurses out beyond like a half an hour perimeter from where we are, but that still does cover a large percentage of our catchment area here in central Massachusetts. And there are other factors that we look at to see whether patients are good candidates for this. But most of the time, we try to get patients from the emergency department. Occasionally, we'll identify them after they've been in the hospital for a day or a couple days, and then we'll bring them home after that to finish their hospital stay at home.
Okay.
Eric, I have a question, just ER based, I guess. So when the ER is looking at their quality data, is this extending the length of stay? Is there like a certain time period that the patient has to stay in the ER? So when a patient is in the ER, when they get admitted, it flags them as an admit. So their length of stay data falls in line with that, right? So now they're not really getting flagged as an admit. Is their ER stay extended past what it would be if they were admitted to the floor versus going back home because you need that time to set everything up in the home?
It's a really good question, and I don't have any data on that. It's the first time I've ever been asked that question. I think you're right. It does take some time to coordinate getting the right, all the transportation and getting the devices that we need, making sure that the nurse is able to meet the patient when they get back to their home. So you're right. It probably does extend the stay in the emergency department to some extent. In many cases at UMass Memorial, those patients would be waiting in the emergency department anyway. We have such long lines to get into our beds that, we wind up boarding a lot of patients in emergency departments, and sometimes that can be more than 24 hours even. And this was one of the main reasons that we decided we wanted to do this. I already mentioned COVID as being a primary reason, but I think we also we don't have enough capacity for the patients that we need to bring into the hospital.
Right.
And in order for us to be able to deliver better care to patients, then, we either have to build a new hospital, which is really expensive, or we can build a hospital in the patient's home, which is much less expensive.
I suspect there's also some patients that actually would do better at home. I'm thinking about some of my, dementia patients or cognitively impaired patients. They get into a alien type of environment that they're not used to, and then they develop delirium and they get confused more, and that has its own risk of medical complication and morbidity, mortality even. So I bet some of these patients actually are better served in the home also.
Well, I think that's part of the punchline that I wanted to get to, Chris, is that we did this primarily as a way to free up inpatient beds so that we could accept the patients that we were turning away transfers for, patients who really needed that tertiary care, subspecialty care that we provide at UMass Memorial Health. I think that what we are finding is that because you get patients into their home and they're with their loved ones, they're with their pets, they're able to eat their food if they want to. We can bring them food if they need it. But they wind up having better outcomes, clinical outcomes. And I think that delirium is one of those things. And we have had cases where, patients are delirious in the emergency department. They're very confused. And the team says, you know what, if we take the patient home, they're going to get better in the home. And they do. They get better much faster when they're around the things that they're familiar with and the people that they're familiar with, instead of all the loud noises and distractions in the emergency department or even on the floors.
Yeah.
Eric, can you talk a little bit about the process? So, okay, Chris goes into the ER, he's elderly. He's going to do the hospital at home program. So when that decision is made I guess, how is that decision made in the ER? Is the ER doc calling or notifying the team? And then can you just...
who's making the decision, right? Is it...
Yeah. Can you just talk through that process of how he eventually gets home and how you set everything up and what doctor has responsibility over Chris at that point? I would imagine it's not his primary, it's a doctor from your program.
Yes, exactly. Yeah. I think it's, we get the referral sometimes from the emergency department, sometimes from the hospitalists who are seeing the patients in the emergency department. That when the decision has been made to admit the patient, they say, geez, I think you'd be a great candidate for this program. And they would send a referral to our team. Our team would review the patient's chart and say, yep, sounds good. At this point, we would talk to the patient and probably the family as well, and say, we got this great new program that we want to, and not that new anymore. It's about 3.5, 4 years old now. We've got this great program that we think you'd be a great candidate for. And what do you think? You'll be able to get the same level of care that you would get if you were actually upstairs in the brick and mortar hospital. And we think it's even better. And most patients say, hell yeah. Let me go home. Some say, I'm sorry, I'm not sure if I was supposed to say the H word here. But,
that's okay. No, that's fine.
You're gonna have to bleep me out here.
We're
just it's just the heavy duty words.
We're PG rated. It's okay, Eric.
Heck yeah. Let me go home to my family and my home. Some patients say, you know what, I just don't think it's right for me. I think I need to be here in the hospital. In some cases, there are some expectations on the family that the family are going to be engaged with care, and sometimes family needs some respite from patients, taking care of patients at home, and they say it's better for the patient to be in the hospital.
Sure.
But I think that's relatively uncommon. I think we out of the patients that we think are good candidates that we approach, then it's probably 2/3 of them say that, yes, I want to go home. At that point, once they agree, once we agree, then we start the wheels in motion. We arrange for transport. We arrange for, within our command center, we get all the different components that the patient needs. We'll get to the patient's home. We meet them when they get there, and then our doctor will conduct a telehealth visit. We'll tuck the patient in. We'll write the orders as if the patient were, just another patient in the hospital. And, that would include any new medications like intravenous antibiotics or the Lasix or whatever else they might need is taken care of. And the patient just continues on their treatment pathway.
Does the nurse and the team essentially meet the patient at home? So they're brought by, EMS or whatnot to their home. Is there someone there when they're there?
Typically there is, or shortly thereafter.
Okay.
That's the best approach, is making sure that they have that continuity from when they leave the emergency department or leave the hospital to when they are transitioned to your team.
So you have a whole protocol of, diagnoses, not really protocol, but a list of diagnoses that make sense that you can take care of patients in this type of setting. I would think that CMS also has a list and you have to follow that, or is that not the case?
There isn't. We actually spent a lot of time before we got the program started trying to come up with our playbook for each one of the things that we thought would be most likely, a patient with atrial fibrillation, a patient with heart failure. And the truth is that as we've gotten more comfortable, we know what we think we're going to be able to take care of patients in the home. We've actually diverged from those initial lists quite a few times. And I can say, we've had, like I said, we've had some very sick patients that we've taken care of very effectively in their homes. One of the examples, we had a young mother who was waiting for a heart-lung transplant, and she had a serious infection in her lung. And she said, I'm not going to be admitted to the hospital. She said, I'm going to sign out against medical advice. And she might have died if she, but we said, you know what, we have this program. We'll take care of you at home. You can get the care at home. And here she is on high flow oxygen with getting, with this serious infection in her lungs, getting antifungal medications and waiting for a transplant, going to bring her in for a cardiac catheterization a few days later. And she did very, very well. We've had patients who have gone on to have transplants after being in the hospital at home program for a period of time, and they come back and they tell us, how well they've done and how much they appreciate the care. But so it's really, as much as we like there to be the kind of the standard cookbook, we take every referral and we evaluate whether we think that we can help patients most effectively in the home. And, so there, in some cases, patients do need to come back to the hospital. Of course, we can't predict exactly, right, how everyone is going to do. We shoot for somewhere in the range of 10% of patients that need to be what we say escalating back to the hospital. It's not, they're not getting readmitted because they're actually admitted to the hospital, just like any other admitted patient. But we escalate them back to the hospital when their oxygen demands get too high, or when they wind up deteriorating more than we expected. Sometimes they need to go to intensive care. And, in some cases, so we try to get it around 10%, because that means that if it's much lower than that, then we're probably not taking enough patients. If it's much higher than that, then we're probably taking patients that really are too sick and shouldn't be getting that. But that's right around where we run, is around 10%.
So along the same lines, I know that you individualize this and look at each case separately, but what would be some of the typical diagnoses that you might be caring for patients with? You mentioned pneumonia already. Delirium was another one.
Yeah.
Heart failure.
Those are the classics. Pneumonia, heart failure, emphysema, infections like skin infections, cellulitis, or bone infections, osteomyelitis, bloodstream infections we take care of commonly as well, patients with infected lines. It's really very flexible, but that's probably, and of course we're in the middle of flu, RSV, and COVID season, so we've been having a good percentage of those patients that have been coming onto service as well.
So I have a couple of observations. If anyone hasn't been hospitalized lately, you don't sleep in a hospital. I imagine people love sleeping in their own beds with their own germs in their own house, because boy, oh boy, there's a lot of noise on a hospital floor, and you could not sleep, especially nurses coming in the room all the time and everything else. So,
sleep deprivation has a set of issues associated.
Exactly. Sure. So my other question is, gosh, these nurses that you have must be crackerjack nurses, because they're really doing some pretty big assessments in the home.
Yeah. We've decided to mostly recruit, and typically they're experienced emergency department nurses, or they're experienced ward nurses.
Yeah.
And what they tell us is that they go into in the emergency department, you go into a patient room and the patient spits at you, or they're mean, or they're frustrated. They've been waiting a long time. They're angry. They just want to get the care done. When they go into the patient's homes, they're greeted with hugs. They're greeted with pets. They're greeted with just a lot more acceptance than the ones. And we've had not a small number of nurses that say, "I've discovered why I decided to become a nurse again."
Exactly.
Because they're able to take care of patients in a place that the patients are much happier.
Yeah, they're not scared and anxious.
Exactly. And maybe they are still, because, everyone who's in the hospital is, you're a little worried about what might happen to you. But I think that being in the comfort of your home with your family, I should have also mentioned, along with the little gizmo we put on the arms, we give patients a tablet, which has a big "I need help" button, and they're able to reach us 24/7. And we've got people who are available to monitor their vital signs 24/7. So if we do see any deterioration or any trends, then that's when we can get our doctors on the line, and we're able to decide whether we need to get the patient back to the hospital, or what else can we do? Can we send someone out to the home now to give the patient some additional medication to help them to feel better one way or another? That's what we do. We may make visits at 2 a.m. to give the patient their antibiotic if they're on an every 6-hour schedule. So it's like being in the hospital, but without nearly as much of the disruption. And I guess, and that's something that I think from a staff experience perspective is much greater we're finding, and then also a patient experience perspective. The patients are just so much happier. That this is the highest performing unit on patient experience in our entire hospital system.
Nice. Congratulations on that.
Yeah.
Yeah, I know
It just makes sense, right?
it does make sense. I mean, when I used to do home visits, and I wish I still could do that, I mean, it was just, it was a really rewarding experience, but you also learn so much more about the patient, the family, the dynamics that you don't get when they walk into your office. Even if they come in with a spouse or a family member, it's just not the same as being in their home and seeing how things work and how they interact with their environment.
Eric.
Yeah, no, I wanted to react to that because it's a really important point. I mean, I think that, and that was something that was totally eye-opening for me. I worked as a hospitalist for 25 years. And the very first patient that we had admitted to the hospital at home program, it turned out, was a hoarder. She hadn't told us this. Our nurses weren't even able to get to the patient's bed because there was so much stuff that was in the patient's space. And that was something that we were able to address, and we helped to get the right resources for the patient so that they were able to be in their environment more safely. I remember one time seeing a patient on a telehealth visit, and this was during he lived in a garage that was next to a family home, and it was during a pretty bad rainstorm, and there's rain coming through the roof onto dripping behind me. Our nurses get into the fridge. They see what food is there. They see how clean or how dirty. They see the McDonald's wrappers in the home. Right. These are things that you would never, ever get insight into if you were taking care of patient in the brick and mortar hospital. And that, it allows us just much better insight to be able to take the next steps that ultimately get the patient on a better pathway towards longer-term health.
That's great.
PrimaCare is Southeastern New England's trusted leader in medical care. With offices in Fall River and surrounding communities, we're dedicated to your well-being. Our carefully selected team of more than 150 providers offers world-class primary and specialty medical care. PrimaCare doctors are supported by a skilled staff trained to deliver comprehensive radiology, imaging, and testing services. PrimaCare is large enough to take care of all your medical needs, but small enough to care for you personally. PrimaCare is by your side.
Eric, with all the gizmos that you have set up in the home and the telehealth visits and everything else, how tech savvy does the patient have to be?
Not really that tech savvy at all. Our nurses will walk people through whatever they need to. Of course, we make sure they know where the I need help button is, and they usually do the vital signs. They'll check the blood pressures when they come in to see the patient. We bring in a Wi-Fi hotspot. So if patients don't have Wi-Fi, then they can be connected. We don't accept choose who to accept based on their insurance or ability to pay or anything. This is and also whether they speak English. We have the ability to get interpreters for any language and whatever condition the patient has. It's really it's designed to be equitable across the board. So we take care of whoever is the right patient for this particular service.
So a lot of the same services you'd have in the hospital, just as like interpreter services and all that, it's all available in the home.
Yeah, it's all the same things. It's just we've just made it available remotely outside the hospital.
Good.
Eric, one thing I was thinking of when I was learning about this program was, the one thing when you're in the hospital and you're elderly and you don't feel good, you have people coming in, washing you and getting you out of bed every day. And I'm thinking, gosh, what these patients might have a tendency just to stay in bed and then they lose their mobility. But you have the whole enchilada. You have all the therapists on your team too. You have PT, OT, speech. That's very hard to get those services sometimes.
So not everybody winds up getting those, and I think it's only the people that need them that we consult them. That is definitely a gap for us in terms of our staffing. We decided to use all of our internal physicians, nurses, paramedics. The other things that we're using and a number of the other services I mentioned, we have contracts with other vendors in the community, including physical therapy and other things that are able to come in, the imaging, et cetera. I think but you make a really, really important point, Nancy, is that when you go into the hospital, people are so afraid that you're going to fall down. And so they tell you not to get up and move and not to walk. In our case, we do the same. I'm sorry. For hospital at home, patients are mobile. They need to be mobile. They need to get back and forth to the bathroom. And they never develop, like what we see in the hospital. When you're sick, you just lay in bed for 3, 4, 5 days, and your muscles become weak, and your body forgets how to walk and stand. And many patients need to ultimately go to rehab as a result, in order to be able to learn to walk again. What we find is that happens hardly ever for our hospital at home patients. They stay mobile. They don't decline nearly as much, and we hardly ever have to send a patient to rehab from hospital at home. Does that mean the patients don't fall at home? No. The rate of falls it's there, but it's lower actually than what you see in the hospital setting. And do bad things happen when patients are at home? Yes, they're hospitalized patients. Bad things happen to patients when they're sick enough to need to be in the hospital. But we find that they happen at a significantly lower rate than what we see in the hospital. And as a result, we do still feel like it's safer than being in the brick and mortar hospital.
Is that rate, that lower rate, takes into account the acuity of the patient also? So if you look at all comers and they're at a certain acuity level, they actually still do better than hospital? Brick and mortar hospital?
The data that we have, where we've looked at comparable hospital medicine patients, hospitalist patients, they have the same case mix index, which is one of the ways that we measure how sick patients are. It's equivalent, what we're taking patients into the home as what's in the hospital. I think one of the differences may be whether they're mobile at baseline, and I don't know whether that's something that distinguishes, because if someone is not really able to get around in their home without a lot of help, then they probably wouldn't be a candidate for hospital at home.
Well, that's actually my next question. Is we talked a lot about some of the patients that would be candidates. Give us some examples of patients that would not be candidates for this program. Obviously, those who are bed fast and can't get out of bed, I would think probably would not be a candidate, but there are others, I'm sure.
Unless they're, unless that's their baseline for a long time, and if they have home, aides or family or
people
used
to help
taking
them,
care of them, we would consider that. Yeah. We don't take patients who are homeless, who are unhoused. That's something that we have not done yet. And even for people that were in shelters or in temporary housing, we don't have the ability to take care of those patients.
Okay.
We would like to say that patients who are, for whatever reason, in unsafe environments, that we wouldn't want to take patients that are it would be a risk to their safety. Although I have to say that there are not a lot of things that truly disqualify patients from that. We don't generally take patients into hospital at home if they don't want us to come.
Okay.
I mean, I think that's one of the main things is that, if we are invading your home, your private space, then that's when patients are going to get really angry and frustrated that you're there.
Sure.
But beyond that, we have a long checklist that we walk through, and I think ultimately we judge what's the risk versus the benefit to getting patients to home. And in many cases, we err on the side of letting people be a candidate if they can be.
That's great.
Eric, is this an adults only program?
It currently is, and we've stuck to medical surgical types of diagnoses. Adult medical geriatric patients are the most common that we have. We've tried to expand a little bit into some of the post-op types of patients. So patients who have undergone colorectal surgery and need a 5 or 6 day recovery, learn how to use an ostomy, that kind of thing. That's gone really well. We've also expanded recently to accept patients who have, moms who have had a C-section. And still need some ongoing care.
Yeah.
But we feel like we can deliver that care safely for the patient at home. Generally uncomplicated deliveries. Now this is not for the baby. The baby is, once they're ready to be discharged, then they go home. But we have the nurses come in to take care of any ongoing issues with the mom for that, whatever 72 hours that patients need to have the ability to get those services after their section. But we're always trying to look for new opportunities and use cases. We are doing blood transfusions in the home now for patients who need them. We've been talking about doing hemodialysis for select patients. We're talking about doing, total parenteral nutrition, patients who aren't able to eat on their own to be able to get that milky white fluid that goes in through patients' veins, so that they can get nutrition, which is something that traditionally would need to be done in the hospital. So there are a number of ways that we're looking to expand the number of patients that we're able to offer this to.
Eric, so when a patient is past that acute phase, because this is considered an acute inpatient stay, it's just at home, right?
Yep.
So when a patient is past that acute phase but still needs skilled nursing, do you transition to another company for that, or do you maintain that patient on your roster?
Yeah, we don't have a visiting nurse agency as part of our organization. So yes, we refer, and then the visiting nurses take over and they figure out, what's the patient's plan for the next, 2 weeks, 4 weeks, 6 weeks, and so on. Yeah, we facilitate those handoffs.
If they had services in the home prior, what happens with those services when you come in? Do they get continued, or do they get put aside for a while, just as a patient would have done in the hospital?
Exactly. They would be suspended while the patient is hospitalized with the hospital at home. Yeah. And then once the patient is ready to discharge, then we would refer back to the agency that was taking care, and they go back onto their regimen.
So, do you have home health aides? Sorry.
No, go ahead. No.
Do you have home health aides then that would wash them up? Because if they have services, part of that service package is the home health aides that will shower them a couple of times a week or wash them. Are you considering this, listen, it's acute, we're going to take care of your immediate health crisis, and then you go back to the services?
Yeah, we do have some medical assistants like we have in the hospital that are able to do some of those things when needed. It's rare that, and I think that the nurses probably help with some of this as well when they go into the homes. It doesn't tend to, they don't tend to require a lot. Again, most patients are mobile. So I think that most are still able to bathe themselves to some extent, but I honestly haven't. Again, I need to ask my team about that one.
I have another question for you. So when they have a crisis, are they on 24-hour monitoring at home, or just those? Do they just get assessed during those 2 visits? How do you pick up on a crisis?
Like a cardiac issue or something?
Well, yeah, just or their SATs 86.
Yep. Yeah. No, we've got the monitor on their arm. We are following their vital signs 24/7. We have a team of people that are able to track that 24/7, and that if they notice that the O2 SATs start to go down, then maybe we need to do something to either reevaluate them. We do see pretty regularly that patients' O2 SATs go down in the middle of the night. A lot of people have sleep apnea that maybe they didn't know that they had. But so, I think sometimes we don't want to overreact when we see some of these values. And I think, we, because now we're in the hospital, you only get your vital signs taken 4 or 6 times a day. Right. But now we're doing it literally every 5 seconds. Nice. So we can see your vital signs even more than what you do in the hospital. So I think we're trained to respond in a way that is going to address the patient's need. And like I say, if it turns out that we do see a significant deterioration, then we'll get someone into the home or get the patient reevaluated back at the emergency department.
All right. I have a couple of questions that are a little different than what we've been talking about in relation to this program. So you've already mentioned that patient experience is superior, and there's some indicators that outcomes are excellent and perhaps better too. There's this whole issue that we all think about medical errors in hospitals and injuries that occur from that. You have obviously you have excellent staff that are, well trained. Do you find that the risk of that or the rate of that has gone down? I mean, it's always hard to figure out the rate of medical error anyway, but what's your sense on that? And then the second question is, do you use artificial intelligence at all with your program?
Yeah, great questions. So first of all, let me talk about some of the outcomes that we tend to look at. For hospitalized patients, we're typically looking at whether patients have things like C. diff infections, whether they have catheter-associated urinary infections, catheter-associated bloodstream infections, blood clots, falls with injury, pressure injuries, the typical kind of things that can go wrong when patients are in the hospital. We have had so few of these that it really doesn't it's hard to count them because again, patients don't have catheters when they're in home. They're moving around, so they don't wind up getting blood clots. The falls are less frequent. Pressure injury doesn't happen because patients are moving. So the outcomes by and large on these kinds of events are much lower. Do errors happen in hospital at home? They do. We have a number of challenges around medication ordering and making, and some of these are the typical things that you would see if a patient was in the hospital, and some of them are unique to this environment where we have to work with pharmacies to make sure that we get the medications delivered to the patient's home and administered in a timely way that kind of falls within that the window of time that we're supposed to give them the medications. So the answer is yes, and just like any other area, we always do analysis and we try to figure out what happened and how we can improve and prevent the next type of error of that nature from happening. And I think we've done a really nice job with that. And I'd say probably many hospital at home programs across the country do that too.
Do you think the rate is less than in an actual brick and mortar hospital, or is there not data currently to support that? My gut feeling is that it's less, but I don't have data that would tell me one way or another.
I can peep in here a little bit because I used to be a quality improvement specialist for our chain of hospitals over here. And a large majority of the medical errors that were made were it was the wrong patient receiving another patient's medication, or the nurse had a very heavy patient load that contributed to an error. So just focusing on that one patient in home, I mean, just automatically.
I would think it would reduce. You would think it would.
Alleviates that. I mean, the errors are going to be if a medication order wasn't written correctly or wasn't followed correctly. It's not going to be someone getting the wrong patient's medication.
Yeah, our nurses, when they do their home visits, they generally are there for a good hour. And they've got 3 patients that they're seeing over the course of their shift. And typically we would have that nurse make 2 visits to the same patient the same day. So 3 patients is what they're carrying for this. And I'm not sure how standard that is across all hospital at home programs, but that's the way we decided to structure it.
Okay.
But yeah, when you're there in the patient's home, you give the patient your undivided attention. You don't have the alarm ringing in the next room. You got to go where the patient's trying to get up out of bed and you need to get them back to bed. They're doing education. They're doing what the patient needs. And I agree that I think that's part of what makes it even safer than what patients experience in the hospital.
And how about the artificial intelligence question? Do you have any? Do you use that at all?
Yeah, we've been working on some questions around this. I think part of our goal has been around how do we optimize getting the patients, the right patients into the hospital at home program, and making sure that there aren't patients that we're missing that really would be good candidates for this. So we've built out some predictive scores within Epic that displays on the screen so that our hospital at home team can look at those patients and see, these are the ones that have that are probably the best match. Excuse me. It's not using true AI yet, but I think it's going to get there. But that's where we think that the the technology is going to be probably first to be adopted. But I also think that, using AI to detect the deteriorations maybe more rapidly would also be something that would be helpful.
That's what I was wondering.
That's something we don't see yet.
I would think that might be a helpful direction to go in down the road. Who first thought of this? Where did this first, where in the country or the world did this first come up? I'm just curious of the history of it.
Johns Hopkins, a geriatrician named Dr. Bruce Leff was the one who initially thought of this and did an initial study. We've seen adoption of this at Mount Sinai and in New York. We've seen Boston at the Brigham. They've done a number of studies and pilots of this. But, this is actually pretty broadly spread at this point. There are somewhere in the range of, I think, 200 hospital at home programs across the country now. And we'd like to see it grow even further and faster. I think one of the things that limited that is that that waiver that allows us to do these services keeps on getting put on the it has a relatively short renewal period. We've initially, when they created the waiver in 2021, they gave us 2 years to evaluate the effectiveness, and from there they renewed it from 2023. They renewed it for an additional 2 years. So that brought us to the end of this past calendar year. We had a 3-month extension from January to March, and then just with the most recent continuing resolution that passed through Congress a couple of days ago, it got extended for another 6 months.
Good.
But it's hard to continue to expand these types of programs while you think that the government isn't going to support or pay for these types of programs. And I should just speak about payment. CMS reimburses this at the same rate as a hospital patient.
Nice.
If the patient, so it, for a hospital, it makes no difference whether they wind up going to hospital at home versus going to the brick and mortar facility.
Nice.
Some of the insurance companies, I'd say most of the insurance companies have followed that lead and also pay at the same rate.
Of course.
Some of them have chosen to either create conditions on that, or they pay a reduced rate compared to what you would get if the patient was in the brick and mortar hospital, and that sometimes results in limiting who's able to be a candidate for the hospital at home program if their payer doesn't pay for that service, or they pay at a lower rate. One thing that has been variable across the country is that some Medicaid pays for hospital at home and others don't. We've been very fortunate in the state of Massachusetts that they've been very supportive of hospital at home from the very start, and they've followed the same protocol. So I think that having the waiver continue and having having ongoing payment, I think, is critical to the success of the ongoing success and growth of hospital at home programs. But I think this has been something that's gone through many different hospitals and it's just gradually spread through some of the great work and the research that's been done up until this point.
I'm thinking as we go through this and talk about it, I'm medical director of a...
I'm sorry, I can't hear you, Chris.
Oh, I'm sorry. So as we talk about this and we go through it, I'm thinking about a program that we're involved with in Fall River, which we don't have this type of a program, unfortunately, but we have a program for our homebound patients, where we have nurse practitioners that go out and visit the patients and help to, care for them. And they really take over their care as the primary. But some of those patients, it's such a hardship even to get into the hospital. But if they required hospitalization, they still would have to come in and go to the ER, and then they could go back home. There's no way around that with this type of a program, I'm thinking, correct?
And unfortunately, the way that the waiver is structured, that's accurate, is that in current state, we couldn't admit somebody directly from home and to keep them there, even when there's a great reason for it. We're also not able to accept observation patients into the hospital at home program. They have to be acute level of care. We need to verify that they meet those criteria. And sorry, there was one other point I wanted to make that I just lost. Yes. So we have been at UMass Memorial looking at other ways to provide care at home as well for patients who are candidates. And I think, instead of making patients come to us, then, for patients who are chronically ill, who have difficulty with transportation, who are maybe at risk of needing an emergency department visit, then we may send a paramedic to their home, and they can be supervised by an emergency medicine physician. We call that mobile integrated health. And that's something that we're doing more and more for patients who are candidates. It sounds kind of similar to the program that you're doing, where you get care to patients in the home. Of course, telehealth has been, really well received, and also a threat of, kind of losing its certification through the government. And most recently we've implemented now a rehab at home program, so that we're able to, for patients who might previously go to an inpatient rehab facility, we're starting to do that rehab with physical therapy and whatever else they might need, instead of them having to go to a physical brick and mortar rehab space as well.
Right.
So we're trying to kind of reimagine the way that we deliver care to patients in the community. I think it's a satisfier for patients, and I think it ultimately leads to really great clinical outcomes too.
It sounds like a fabulous program. I wish we had it down here, but we don't.
Oh, I'm so jealous. Eric, what about lab work? Do you draw labs in the home?
Yeah.
That's so sweet.
Well, for the hospital at home program, yes, we do. The nurses, when they go in, they'll draw labs. If
Nice.
And similarly, if we have one of those mobile integrated health visits, the paramedic comes in and they determine the patient needs some blood work, then we could draw some blood, and then we could get the results and act on those results. But it's not something that we do frequently. It's
Of course.
usually by exception.
You can get X-rays too, and imaging such as ultrasound and all of that.
How long do patients stay on the program, or is it very independently based? It's
just like
you
a
have a need, you
hospitalization,
just stay.
Like any hospitalization.
Yeah.
Okay.
Like any hospitalization, sometimes it's 2 days, sometimes it's 2 weeks or longer,
So there's no cutoff. The government doesn't say that. It's just like if they meet the criteria for an acute hospitalization, then they can have that hospitalization at home, basically.
Yes.
So sometimes a patient sees a specialist, like if they have an exacerbation of COPD, or if they're vented or what have you.
Yeah.
So do then you have a pulmonologist who comes on board, or like a specialist? Oh my God, you have everything.
Yeah. We can consult whoever we want in the hospital. We have the telehealth platform that they're able to evaluate the patient. And, it's the rare situation where they actually need to see the patient in person in order to issue recommendations. But occasionally we will bring patients back into a clinic space where they can do an examination when necessary. But for pulmonary and, many of the other things, GI, infectious disease, they do it all through telehealth.
That's great.
We find that we have, great outcomes there too.
I have informatics question for you next. So,
sure.
like if I go to my doctor's office, or if I have lab work drawn, I can go on my patient portal and see my results right away. Do they have access to their information in real time through a portal? Oh, wow.
They do. They do, because all of their information's in Epic. Then they get my chart, and they're able to access all of their information as it comes in. Sometimes if we schedule things, they can see what their schedule is as well, so they can understand when people are going to come visit. And so yeah, that works out really well too.
So Eric, what do you think are the next steps for the program?
I'd say growth. We keep on trying to grow the program. It's not an inexpensive program to run. We have found that it costs about the same to take care of patients in the hospital at home as it does on one of our medical surgical units. It requires a lot of nursing. It requires physicians. And I think, and what we're finding is that in many cases, our program is capped, that we don't have the capacity to take additional patients on a day-by-day basis. So it's just about how do we continue to, I think we're always looking for more patients that meet the criteria, but making sure that we have the staff, we have the capacity to take patients when they meet the criteria. I think is the Chief Quality Officer for Health for UMass Memorial Health. I view this as kind of my mission, is to get as many patients access to this, because they do have such higher quality outcomes than what we sometimes see in the hospital.
Fascinating, huh?
I am so jealous. Can you do something? Bring this program here.
Well, we might. It's something to consider, definitely. I think the Fall River community would definitely benefit from it.
Yeah, I mean,
and
God.
I'll talk to Eric more about how we can extend it. We can do our own program here in this area, because it would be...
It's a perfect utilization of resources.
It would be great for many of our patients. So as we draw to a close, it's already been an hour, unbelievably. Time really goes by quickly when we get into these conversations. Is there one
discussion?
It's been fabulous. Is there one message you'd like to leave our audience with?
I think, thanks for listening. Thanks for considering this option. I think that it's just a really great way to receive healthcare. I'd say talk to your legislators to tell them to continue to make this program available for more and more patients, because again, until you have some more stability in this waiver, then it's hard for places like, the areas that don't have this to be able to build these programs. If you're approached as a candidate, then I'd say, give it a shot. I think you'll find that it's a really great way to experience care. And I think we're just going to be seeing more and more of this type of innovation in the near future. It strikes me always as kind of funny that, back in the 1900s or 1800s, doctors used to do home visits. And then it was, more recently that we created these things called hospitals to put all these sick patients in a single place to take care of their illnesses. And I think it's the technology, it's using these digital monitoring resources that enables us to get back to the patient's home, which I think makes it, it's a more powerful way to get care.
That's great. Well, I love the personal approach to it. How it's all individualized. I love the fact that patients have better patient experiences, and that the outcomes are, in many instances, it seems like they're better in some instances, which is great. So it's wonderful. Maybe we'll get it down the Fall River area.
Really hope
Something
so.
I'll have to look into, see if we can work on that. But thank you. I want to thank my good friend, Dr. Eric Alper, for being on the show. This was actually really, really fascinating. And I learned a lot, and I'm sure you did, Nancy, and I'm sure our audience did also.
Yeah, definitely.
So I want to also thank all of you for listening to our show. And if you'd like to become a sponsor, please contact us at 617-775-3737. And special thanks to Ron Gamache for our intro music, Primacure, your trusted medical providers in southeastern New England, and the Bioskills of Northeast for producing our show, and available to produce your show by calling 774-301-8811. And they do a great job. Bay Coast Bank, just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. And Duncan Hearing Healthcare you can trust, with sites in Fall River, Dartmouth, Falmouth, and Centerville. For more information, visit their website, duncanhearing.com. And then, Eric, once again, thank you. This was a great podcast, a great discussion. We really enjoyed it, and I learned a lot. I know Nancy did. I think everyone out there did too. And hopefully we see more of these programs as time goes on.
And thanks so much for having me and letting me share some of this great experience with your community too.
Yeah, once again, thank you. Take care, and I'm sure we'll be talking soon.
Bye.
That was great.
Bye-bye.